Good morning, everyone. Let's start our early morning session about psychodermatology in aesthetic practice and how to combine our mind to skin in this mind-skin axis approach. So we start with Dr. Cezanne Antonio. He will be talking about psychodermatology and aesthetics and a focus on the body. Thank you.
Yes, thank you very much for that very kind introduction. Okay, so good morning, everyone. My task for this morning is to talk about psychodermatology and aesthetics, particularly focus on body dysmorphic disorder. This is my disclosure, and these are my objectives. Let us begin. Psychodermatology is an interdisciplinary field that studies the interaction between psychological processes, and skin disease. It recognizes the bidirectional relationship between the brain and skin, whereby psychological stress can influence skin disease and dermatologic disorders can adversely affect mental health. I'd like to explain there are three clinical models of psychodermatology. The first model is the psychophysiologic disorders. It is a primarily dermatologic condition which is exacerbated by stress. And that, I think, as dermatologists, you would actually be seeing a lot of this in the clinic. The second model, it is primarily a psychiatric disorders with cutaneous manifestations. The psychiatric illness is primary and produces skin findings. An example for which would be trichotillomania, wherein the repetitive hair pulling results in alopecia. The third model is secondary psychiatric disorders. This means that psychiatric symptoms develop as a consequence of skin disease. I would like to also explain when we talk about this, there's a big difference between a patient being depressed versus a patient having clinical disorder. A patient being depressed is still within the normal range of reactions, whereas if you have clinical disorders, you already have all the clinical symptoms and as such would necessitate referral to a mental health professional. One secondary, good morning, welcome.
You know, if you click one more, it'll come on your screen, apparently.
I'm sorry, could you repeat that?
If you click one more,
One more?
it'll come onto your screen. There's a way of doing it. Maybe you're happy with it because it's very hard to read that.
I know it's too small.
So,
Yeah.
so there's a way of doing it.
I have to make it larger?
Yeah,
Oh,
she'd probably be able to do it because Diane Duncan yesterday couldn't read her thing.
it's too small for me.
Could you
Enlarge?
make that so it goes onto the
Yeah.
screen?
That's fine, actually, yes. Okay, thank you for that. I just would like to know who I'm lecturing it. Could we just explain your aesthetic dermatologist?
I'm unusual. I sit halfway between dermatology, general practice, and plastic surgery. So
Oh, so your three
do also
hats.
skin cancers.
Skin cancers and dermatology and plastic surgery. Okay, very good. So at least we know. And oh, we have another audience coming in. Welcome, thank you. He's not a speaker. He is after an audience. He's not the speaker. So he's an authentic audience. Thank you.
He gets a prize.
Of course. Of course. We deal beyond the skin. We deal with brain-skin axis.
And Thomas Rappel will be arriving as a plastic surgeon.
Perfect. I think this is a wonderful melange of different specialties. Now, let us now talk to body dysmorphic disorder, which is essentially belongs to the category, it's a primarily psychiatric condition. I'll begin that when we talk about body dysmorphic disorder, there are several criteria. One, this person is preoccupied with appearance. 2, there is repetitive behaviors or mental acts, typically always checking in the mirror. C, there's clinical distress or impairment. By that, meaning to say the work or social sphere of this patient is already affected. Meaning to say, oh, you know, this is so disgusting, I don't want to go out socially, or it may affect performance at work. And C, as in all psychiatric conditions, there's always an exclusion, and for this exclusion of eating disorders. Now, let's talk about epidemiology. How significant is this? When we talk about general population, it's approximately 1 to 2%. However, in dermatology patients, the prevalence increases exponentially to 12.6%. And in plastic surgery patients, which some of you are cosmetic surgeons here, it even increases to 15%. Moreover, approximately 12.6% of patients you would see in a dermatology practice may actually have symptoms or traits of body dysmorphic disorder. So therefore, that means dermatologists are often the first physicians consulted for skin and facial concerns, and among the most common body dysmorphic which are among the most common body dysmorphic preoccupations. What is so special, what is unique about patients with body dysmorphic disorders? Most remain dissatisfied after treatment. You do your best, and objectively speaking, all aligned. I want this, everything, but they're still unsatisfied. And at times, the concern may shift to another body part, and what is worse about it is that the symptoms worsen after procedures. You do have to understand this is primarily driven by a psychiatric condition, and you're trying to address this by cosmetic or dermatology procedures, and therefore it's not aligned. For mental distress, you would also need mental interventions as well. So here are some behavioral signs in your patients that may make you expect excessive mirror checking, multiple consultations, doctor shopping. I've been to, this clinic, I've been to this clinic. They've all disappointed me. I know you won't. Frequent requests for revisions, bringing heavily edited selfies, excessive use of beauty filters. Moreover, when you check through the history, there are multiple prior procedures, persistent dissatisfaction, unrealistic expectations, resulting in social withdrawal. What is very concerning about patients with body dysmorphic disorder is that there are increased rates of complaints, which may result to litigation, dissatisfaction, conflict with practitioners, and therefore you have to equip yourself with proper documentation screening and of course the informed consent as part of your risk management strategies. In screening your patients, you avoid inappropriate procedures, you avoid patient dissatisfaction, hopefully litigation, and ethical violations. Now, in your clinic, there are actually several screening tools you may use, and I'd like to specifically focus on the first one, which is Body Dysmorphic Disorder Questionnaire, dermatology version. It is actually a short version, approximately about 7 items. It is highly sensitive, highly specific, and easy to incorporate in intake forms. The only thing about this is that it is copyrighted. And it's recommended for use for all cosmetic consultation patients. But if I would advise if you're going to use screening forms, and I would actually advise you use more than just a body dysmorphic and do so in the clinic, you may consider writing a paper or doing case series on this, because once you pick up a patient which may be positive from there, that is when you start with another conversation. Now, once you do have the screening tool, you essentially have something written with an actual score. And therefore, you will discuss this with the patient, say, I would like us to work together, and I want you to be happy. I see in the screening tool, you have an elevated result here. That means you have psychosocial concerns. I'm concerned with this because if we don't address this, you're not going to be happy. How do you feel about that? And why don't we address all of the boxes, not only the cosmetic part, but also the psychosocial part? I think as you will be seeing more patients, you will be having develop your own style in having this conversation. And of course, with that comes you may have to delay the referral and also gently prod that, you know, I would like to help you. However, I'm not trained in this. May I refer you to somebody better trained so we can address your concerns. So the key takeaway message is that body dysmorphic is common in dermatology and aesthetic medicine. And dermatologists are often the first physicians consulted. Cosmetic procedures rarely improve body dysmorphic disorder. They may not go back to your complaint, but they will be to your oral colleague, and you might realize, you know, during dinner that she or he has consulted all of you. Early recognition protects both patient and physicians, and screening tools, not just body dysmorphic, could be easily integrated in aesthetic consultations. With that, these are my references, and thank you very much for listening.
Now the floor is for Dr. Tracy, my co-chair. Dr. Tracy is a winner AIDA Award, is the most awarded doctor globally, is a top aesthetic doctor in the world, is also a top aesthetic doctor in UK, Ireland. He's also a board member in MCAS academies and all MCASs globally. Thank you, Patrick.
Thank you, Dalia. It's funny, I have a little secret to tell you. You asked me to do this last year in Paris, and I made a mistake. I didn't upload my lecture beforehand. So then Hugh asked all the board out for a special dinner down the city, and I had my lecture in the pocket of my jacket. And I never got my jacket. Somebody stole it in the restaurant, and I went back the next morning, it was gone. So I was in a situation where I had to give a lecture with no lecture. Okay, so what I did was something totally different. I took the concept of psycholag, and I hadn't really applied it to skin per se, so I took it to the Irish famine and the coffin ships going across the Atlantic and people leaving behind all their dead relatives because the British did genocide at the time in Ireland, and some of the people going across the sea had to be thrown overboard because they died. And then people arrived in New York with all those memories. And the people who retained the memories of back home and their partner's loss didn't do that well in New York. But those that quickly forgot it became jobs as politicians, policemen, all the 4 Ps, priests, blah, blah, blah. And so that was the concept of psycholag long ago before it came into dermatology per se. And then my lecture really was about looking at the difference between biologics and methotrexate in particularly psoriasis on the PSA side. So we had noted that people who have biologics quickly go through psycholag compared to people who use methotrexate because they have sort of memories. So for the people who were interested per se, I don't think this is working. I'll use this. The people who were interested, I put, because I got a standing ovation at that lecture, even though, again, there was only a group of people at it, and I put it on YouTube. So these are some books of mine that actually, believe it or not, went on Amazon this morning, those last 2. So what is psycholag per se? I'll go through this. So it's the interaction or the interface between dermatology, psychiatry, and psychology. And we know that the skin and brain are very closely connected because anatomically they both come from the ectoderm. Even though there is a difference, I had a lecture for BTL on the exomind, and there's no doubt about it that the connection is directly there. So anything that happens in the skin can affect, obviously through cortisol and inflammatory markers, the brain, and anything that happens within the brain You know yourself, from young brides get married, suddenly they get acne and psoriasis gets worse. So we run into a loop there. And this brain-skin immune axis is dependent within this loop. So we've got inflammatory processes releasing the cytokines, the chemokines that go around in a circle, particularly through Kilram. So this type of mind-body connection is really important because we always miss it. Most of my practice is dermatology, and certainly if you, particularly with patients that come into you we do a lot of ablative laser surfacing, and the people carry the memories of the scars even after they've healed, and people tell them that, look, it's gone, and their own relatives say it's gone, but you could still know that. I find it particularly with psoriasis patients, if you say, listen, we're on a pathway here, or Roaccutane for acne, because it's not going to kick in for 3 or 4 months, and as a consequence, if you take them through that journey, they do much better, and they're the ones that write you your reviews per se. So Cycalog in dermatology, that's the picture of our office per se. So it's the delay between the physical improvement in the skin or face and the patient's psychological acceptance of that happened. So in simple terms, the skin may improve, but the mind takes a while to catch up. So the mirror image has changed, but their internal self-image hasn't as yet. So again, this is just a repeat per se. It's the delay between the physical improvement in the skin and the patient's psychological acceptance of that. So this is repeating itself to an extent as well. Why does it occur? And this is a very important thing because it occurs usually in the mating period of life. The same way as we came up with FUE many years ago and hair transplant instead of FUT, because I noticed, like, I had 23 hair clinics around the world at one stage, and most of our patients were 18 to 21, whereas the old FUT was, they did it when it was too late. You could only do it once as a strip, and they were doing it at 45. Same as breast enlargement. You need to do it when you're 18 or 21, when you're, because there's secondary sexual characteristics. I only mention this because these skin conditions also happen in that period, you know, 15 to 18, 19. And people remember this because they get tormented at school, or they're embarrassed to go out to a dance or whatever, and they're meeting their mate in life. So you get this learned behavior of avoidance, and Fernando will be chatting about this later as well, and of course the mirror checking, even though it's psychiatric rather than psychological per se. So you get this body image distortion. And people forget also that you don't need your eyes to see. You know, if you're taking drugs, you can see. If you're dreaming, you can see, because there's two different parts of life, and most doctors forget this. There's your eyes that create perception, but perception in the brain is a totally different thing. You don't need eyes to do that, which is the reason that anorexia nervosa and all these BDDs exist, because what they see in perception is actually different than you're seeing just your eyes in front of it. And we really should understand this a little better, to say. The second big thing, of course, is the fear of relapse. Just when they've got over everything, they're afraid it might come back. Morning, Thomas. Good to see you. So this is the other plastic surgeon to make up the balance, per se. You're not getting me on video there, Fernando. I thought you were going to do some videos. You're the worst photographer I've ever allowed. So I'll let you go again, and I need at least 3 minutes of this for my Instagram. Okay. So maybe you should give it to Hugh. He knows how to use it. But he's taking pictures of the floor, not of me. You're doing videos now, not photographs. Good stuff. Thanks for that. So we're back to fear of relapse. That's one of the big things, that even when it's gone, they're afraid it'll come back. And we particularly noted this during the period of psoriasis with methotrexate. People fear that because it takes so long to work compared to biologics, that it may sort of come back again. So in terms of psoriasis, and I wanted to sort of focus on this to an extent, We know it's chronic relapse and it's related directly to the brain. So as a consequence, the potential for coming back is certainly there. And I often notice we get wonderful results with methotrexate per se, but sometimes you get liver function abnormalities or they're running at 30 milligrams, so we have to switch them over hospital consultants with biologics. And it is one of the most wonderful interfaces for actually seeing the effect of Cyclag. So you find that sometimes patients will come back to you, even though they're clear, and they're still avoiding social contact. They remember the memories of being slagged at school, those type of things. And those patients have a high fear as well, and they have anxiety and depression. So this is some studies that have been done, not by myself, but by some of my colleagues, that shows that personalized medicine, like biologics, are much more effective in reducing Cyclag per se. Now, MTX, we all know, most of us are dermatologists. Plastic surgeons in the room like Thomas, methotrexate is a drug we use in dermatology. I'm only joking. Biologics per se, okay. The big benefit of biologics, of course, are improved sleep and mood, reduced depression, anxiety scores, improved work relationships. This is another big thing we have to take into account, how people actually interact at work. And particularly we see this with hyperhidrosis and PAM. We know that people who do get a lot of sweating in their hands, they don't progress through the company as fast because they don't shake hands with people, they don't carry books or notes from one place to another. And really, Cyclag is so important with Botox and sweating on hands. And if you want as well, you can actually add in different profiles to the Botox to make it work better. We do it to an extent. So I'd said that psoriasis is more than a skin disease. Obviously, it carries depression, anxiety, per se. And the medicine that I was going to mention to you there in terms of Botox is hyaluronidase. If you add some hyaluronidase to your Botox, it'll work better per se. So the burden of psoriasis is obviously loss of identity, body image disturbance, hypervigilance, and there are scores on this if you look up the internet, how you can map it, how it disappears per se, and that's the psychological burden of it per se. And this has been well demonstrated as a psychological difference, and most of the work in Cyclag in dermatology has been done through psoriasis and methotrexate. So the skin may clear, but the shame doesn't totally resolve. The fear of relapse diminishes, and biologics shorten the gap between physical clearance and psychological recovery. Acne scarring is something that we see all the time, and we can actually get a much better result and response from our patients if we're aware of the fact that they're going through this, and even though we're standing in front of them saying, God, your skin's clearing, you're beginning to look good, that may not be their memory of their old face per se. So once we begin to understand the brain-skin axis per se, we'll get a much better interaction with our patients. So I actually came up with this little badge. Not every disability is visible. Well, I didn't. AI did, actually. And biologics will often clear the invisible disability that sort of we carry per se. A lot of, I suppose, work on it already. And that really is the basis of my lecture. I hope I'm running on time. And this is our role as clinicians, that sort of we are aware of Cyclag and that we screen for it per se. Thank you. And I have to go to do an interview upstairs in a moment, but I'll stay until 10. You missed all that, Fernando.
No, I did a pretty good job.
Did you? Okay. I'll give you marks out of 10 later. Thank you.
Thank you very much, Patrick. Now it's for Dr. Rappel Thomas. He's based in Austria. He's a plastic surgeon. Thank you, Thomas, for joining us this morning. So Thomas will be discussing the dysmorphic syndrome in his practice. Is it becoming a big problem? Thank you.
Yes, thank you. It's wonderful to be here. And good morning. Well, as we know that this dysmorphia it appeared in Herodotus before Christ, was 400 before Christ, and this was the story of the myth of the ugliest girl in Sparta. And then, luckily enough, that there was Sigmund Freud and Morselli who first described this. So something which comes from our home country, and probably it was the Austrians which have these problems a little bit more. That's why all those problems occur. And probably we see in our practice all those things. Maybe we cannot check this enough. So the Journal of Family Medicine, if you look at this, it shows you that there's a rising dysmorphia among adolescents. Is the cause for concern. And the problem, I think, today is due to the fact that all those children are getting into the social media, and they're pushing themselves into spheres which make it problematic to live a normal life. I think this will aggravate in the future and will be an upcoming problem, which is even more now in the upcoming years. The recognition and treatment is essential. So if you have to talk to the patient, of course, this is normal. We all do it, but sometimes we should take more time for it, because you have to analyze the patients and to look if there's about the conditions. Because as you see in this paper, in UK rates, the suicide rates among the 10 to 24 years old have increased significantly, but not only in the UK, it's all over the world. So also, if you see in the US, there's 1 in 5 people who experience body dysmorphic syndromes, and this is something which we really should be aware of. And I also think it's, as Patrick says, it's not visible that much, but in the end, we have to deal with. Now I have a little video for you where you just have to look at the cross in the middle. And when it starts, you just look at the cross. And you see this is happening right away, and you look just in the cross. This is probably happening, what happens to the people. They don't see each other in the mirror. They don't see each other they don't see the person they are, and that's why they're focusing on things which might be not there. So the syndromes, it's a mental health disorder, and lasts long time often, but it can get better with the help of a little bit of psychotherapy. I think that's the most important. If you think you have a BDD patient, don't try to be the psychologist, just look for a colleague who might help him out. They are concerned about their inactivity, to be unattractive. Usually they're obsessed with their look and almost judging themselves in a negative light. They spend a lot of time looking and trying to change their physical appearance. They can develop eating disorders, become self-injuries, and just want to change their body, and at least they can be suicidal. The first conditions, they consist in sudden appearance and fixation of consciousness of the idea of one's own deformity. The individual fears that have become deformed, so dysmorphous, that's where the name comes from, or might become deformed. The fears are almost there of developing dysmorphic situations, so they constantly peer in the mirror. This is something also if they're sitting in your office and they're almost checking their phones, checking their mirrors, discussing about their looks. And it's just an emotion. The emotion becomes fear, distress, and anxiety. And on the psychological phenomenon, has gone beyond the bounds of normal. That is the problem. So it's a psychopathological disorder. The main symptoms, again, are mirror checking, camouflaging, the makeup, skin picking, comparing appearance, and this is where we are now comparing, and then we come back into the social media. Social media is more or less only to compare with others, so they compare with fake photos and want to look like that, and that's why the younger population is stepping more and more with the stress into this dysmorphic syndromes, reassuring the seeking, excessive grooming, and excessive tanning. Health-related quality of life. So again, the problem is that the suicide rate is enormously increasing nowadays, and also the problematic situations with the family, their friends, and also tend to get out of the social life. So they experience distress leading to significant impairment in their daily functioning, and overall health-related quality of life is diminishing. The diagnosis, there's a manual where you have to go to, and with this manual of mental disorders, you have a clear guidelines how to deal with that, but the best, if you have it, of course, you have to send them away. Overfilling and body dysmorphic disorder, does it go along? Yes, it does. So the problem isn't that what we see in our office, that people sometimes don't recognize themselves when they look into the mirror. They look into the mirror and they don't see the patient they are. So a nice story of my office is that overfilled lips come into it, and then she said suddenly she wants to get dissolved. And I said, why does it take so long? It takes like 5 years you go running around with those lips, and she said to me, I didn't see it. And I said, why? And what was the reason you come? And I think the most important thing is that they have friends who say, okay, you look like that, please do something against it. And it was a colleague of us, and their friends said, you must dissolve this. And then she came. Then she saw her real photo or her real picture in the mirror. And then she came to dissolve. And I think this is also the good part of our job. Then probably with doing it in a proper way, in the either or in the other way, to recreate or to dissolve, you can help the patients as well, but also in combination with a psychotherapist. Supranormal stimuli and too much of dermal filler. It is supernormal. It's like the particular looks are supernormal, more than normal, which also is something problematic when you look in the social media, and you will see that patient with thick lips are gathering around with other patients with thick lips. Patients with big breasts are getting around with patients with this kind of look. So super normal then becomes quickly as normal because they're living in an environment where it looks like it is the most beautiful, and you get the feel they feel fantastic, and it's so fantastic to feel for a week, and then it's about the happiness level. So they feel fantastic, the happiness level raises, and to return to normal is not easy because then the happiness is of course gone. So there's almost a question between good and evil. And if you choose between good and evil, there's just a thin line. And it's up to you to check in which direction you go. And I think it's an obligation to us as practitioners, surgeons, and dermatologists, whatever. To start with this, what's the take home for our practice? Just use and start with smaller amounts of dermal fillers. Of course, the informed consent is very important. And overfilling, it has some psychological implications as overfilled keep on filling, and overfilled becomes the norm. This is a problem what we see, and that's why it looks that overfilled persons, this is just a cultural thing. In some nations you see more, in other nations you see less overfilled persons. But again, this is something because people are surrounded and are also looking in the social media. Again, if you're looking for big lips in the social media, then you will get all the time big lips, even more every day. And so for them, it becomes normal. This is some nice video which shows about the reverse selfie. Let's see if it works. Oh, it doesn't work. Okay. And this shows you everything about social media, how the life is. They're working on these pictures. They're trying to change themselves, their appearance. And what we see as well is all those ladies are changing their pictures, they're camouflaging, they're putting filters on. And they know that they do it, but when they see other ladies, other girls in the social media, they don't think that they are as well camouflaged, and they believe that this is the reality. And I think this is another problem which we have to deal with it, because the pressure is really, really enormous. Again, social media is a problem, so we skip over it. We know and the influence of dermal fillers is like promoting, and the use of the age groups is enormous, like you see here. 85% in the 16 to 25 years old population, they almost look in the social media and become really stressed by that. And the snapshot dysmorphia is something which came out of this, and we all see this. Daily spent using social media, like you see here, 16 to 24-year-old patients, nearly 3 hours. The female, almost the females a little bit more. Of course, if we go down to the line to the 55 to 64-old patients, is only 1.5, but also increasingly in any population and any age content. Relations between health-related quality and life and dysmorphic disorder. There's a rising number of non-surgical aesthetic treatments, we know this, and the growing usage of social media elevated the numbers of BDD in patients seeking aesthetic assistance, and this has been reported. So the deal is you have to reduce social media, but it's not easy, but there are now trends like we have in Europe, in Austria, and I think in England now, that they're allowed, under 16, they're not allowed to use them. I found this is a very good turn to, because only there maybe you help them. Nevertheless, they will find ways to get into it again. And this is an experience which was done in Austria this year. So they tried to they put away in all the schools, 3 weeks without smartphone. And the experience showed that 30% less depressive symptoms were there. So this is really something which underlines the problems, and also underlines the problem of social media, and that there is a way out. Evidence-based therapies for BDDs, it is the cognitive behavior therapy, dialectical behavior therapy, acceptance and commitment therapy. Nevertheless, should we treat or should we not treat? Again, I think you should discuss with a psychologist how far you can go, but there is a benefit for you, and this has also been, there's just one paper in the literature which shows that if you do the right job to the right person, of course it's in any way, but also if it's a BDT patient, you probably help them. Also, something which is going in this direction is for mammoplasty. So if they have amastia and you make a good augmentation, then you really, really help them. Also for the in this case. The conclusion, although aesthetic treatments seem to have strong positive impact on the quality of life for patients without PVD, there is a strong recommendation not to treat patients suffering with surgical and non-surgical aesthetic procedures without concerning a psychiatric specialist first, and then you can discuss, and when you discuss the problems, then you can go for it, but discuss it first. With this, I want to thank you and invite you to Paris in next year. Hope we see each other in January. Thank you very much.
Thank you very much for that, Thomas. And the interesting thing is that before Austria and Britain, they did this in Australia first. And a bit like when we were going through med school, we'd seen that cervical cancer in Britain was 3,300 per year. And when they introduced the pap smear, it never dropped, because the very 8% who didn't turn up for the pap smear were the people who were getting all the cancers, and they just weren't, just mostly prostitutes and all the rest. And apparently it's the same with social media. The very people who you want to target are using VPNs and everything to actually stay on social media. Yeah, interesting. So Diala is up next, and she's going to tell us the interaction between psychodermatology, aesthetics, and longevity medicine.
So good morning, everyone. So today we'll go beyond lesions and lab values to explore something less visible but equally powerful, the psychological improvements of our skin health and our body. Our skin is not only a physical barrier, it's a living sensory interface that constantly communicates with our internal world. It's a sensor, detector, external stimuli, but also a mirror reflecting what happens within our emotions, our stress, and our overall well-being. So psychodermatology bridges dermatology and psychology. The pathway is bidirectional. Stress, anxiety, and depression can flare skin disease, and visible skin symptoms can worsen mental health. This fuels a cycle. Symptoms drive stress, stress drives inflammation, and inflammation drives more symptoms. Our job here is to interrupt that loop ideally early. The first systemic review explores the link between atopic dermatitis and obsessive compulsive disorder. They confirmed a significant bidirectional association between these two conditions. Patients with atopic dermatitis show higher rates of obsessive and compulsive behaviors. The second review highlights a consistent association between rosacea and anxiety, depression, and social phobia. The visibility of symptoms, flushing, redness, papules creates a constant sense of self-consciousness, often leading to avoidance of social and professional interactions. Let's ground this in numbers. Up to 30 to 50% of dermatology patients have meaningful psychological distress. In acne, depression rates we have roughly 2 to 3 times higher than controls. And in psoriasis, up to 1 in 5 patients will report suicidal ideation. Stigma, avoidance of social events, and isolation are also common. Stress activates the HPA axis, therefore cortisol and neuropeptides increase. The result would be barrier dysfunction, pruritus, delayed wound healing, and amplified inflammation. That means that we will have a slower recovery after procedures, more itch, scratch, cycles in eczema, and flares in acne and psoriasis. Visible conditions as acne, vitiligo, scarring, reshaped self-image, adolescents and young adults here are particularly vulnerable. BDD affects around 2% of general population and rates are higher in cosmetic settings, as discussed previously. Meaning many of us already see patients suffering of BDD weekly without meaning it. Social media amplifies appearance, anxiety through comparison, common culture, and spending our time editing our selfies. Structured psychological tools help quickly. The cognitive behavior therapy reduces scratching and improves regimen adherence. Mindfulness lowers perceived stress and itch intensity and improves quality of life. Biofeedback teaches patients to modulate psychological arousal, and support groups reduce isolation and improve coping, particularly for chronic visible conditions. Integrated models pair dermatologists and psychologists, sometimes in the same visit. Quick note here about our hair. It has a unique psychological weight. Trichope psychology explores this deep connection. It's not just a biological structure, but a symbol of identity, vitality, and even social belonging. In fact, the emotional burden of hair loss is often greater than the physical symptoms. We see this daily. Patients with alopecia or patterned hair loss who report not only reduced confidence, but also increased anxiety and social withdrawal. The skin listens to the mind, and the mind responds to the skin. When we understand this dual role, we begin to see skin conditions not as isolated dermatological issues, but as an integrated mind-body experience. Healthy skin starts in the mind and will take care of both. Thank you very much.
Thank you for that, Diala.
Thank you.
And now we have an interesting lecture from Fernando. So he's going to integrate actually anthropology into his lecture, which is going to be interesting. We need a bit of anthropology this morning, I think, to wake us all up.
Good morning, everyone. Thank you for the invitation. And I think that this topic and the session is crucial. We work in enhancing beauty. So we really need to do the question, what is beauty and why we're so obsessed by beauty? And why it's important? Because nowadays with social media and with all the inputs we have, our adolescents and younger persons are really suffering, and we have to understand them in order to help them better. My conflicts of interest, actually none for this topic, and we need to understand that beauty, it's not only the appearance, and we have basically 3 ways to see it. Let me show you with the pointer. So we have the beauty, it's a signal of health, fertility, vitality, and that's why we tend to look younger, and we want to look younger all the time, because it shows that we are fertile. But it's not only this. We have also a social language, and that's what's happening with social media. If I use social media and, you know, with the logarithm, we always see like our same group, our same ideas, and so persons are trying to belong to a group. So they will try to look similar to, and as it has been said, if all of my peers have very thick lips, I wanted to belong and I want to do the same thing. But also there is a psychological burden we have to be aware, the validation, and this is crucial nowadays, for especially in adolescence. It's a period of time where we want to be validated by the group, but we can suffer for anxiety and distortion. So let's deconstruct a little bit the beauty. So we have this biological, the first, I think it's the more obvious way to understand beauty. So we have some unconscious signs looking for a connection and reproductive, if we want to see simple. But also we have this social cultural construction, and that's the idea of belong to a group, or belong to a country, and it's important because it changes through history, and it's not only in this era, and I will show you that it has happened all the time. And also the psychological consequences, because we want to have this validation, but sometimes we suffer because we think that we are not good enough. But let's see how is the definition of beauty, and we have some of our philosophers telling us what is beauty, because if we think today a definition, it's not going to be so simple. Sometimes we see like really ugly persons to us, and they think that they are beautiful. So Plato thought that beauty reflects the divine perfection, and so this is the first idea. So we tend to see beauty, and we feel better. It's like a divine inspiration. But then Aristotle thinks that beauty, it's harmony, the proportion. This is the classic way we understand beauty. So the proportions, the symmetry, etc. But then Kant think that beauty, it's subjective. So we have something in common, but we have some differences. And I think that this is today's idea. So we have some groups where they can be totally different from each other, but with the sense of belonging, they feel beautiful and they change their bodies in order to belong. So let's see, the first one to understand it's a biological way to be beautiful, and here it's symmetry, and it indicates that we have a very good genetic background, but also we have a stability during our childhood and adolescence, so we have food and energy to grow and to basically be prepared to be father or mother. So it's very important, and people who suffered, for example, from problems with food or with acne or psoriasis or vitiligo during the adolescence, they suffered a lot because they don't feel that they are good enough for partnership. But not only the symmetry is important, but also the brightness, because it's a signal to feel young and to feel energetic. So I think that most of our patients, when they are in our consultation, they are looking for both of them. But also, don't forget the ornamentation. This is something to demonstrate that we have resources and we have the ability to display rings, necklace, etc. And of course, the sexual selection. Actually, this biological way to see beauty, it's about the sexual selection. And it works as an adaptive mechanism favoring like a good health and reproductive fitness. But we also have this neurobiological way to see the beauty, and here we have the dopamine reward pathway. So when we see something beautiful, and when we see us in the mirror, and we think we have some beauty inside, there's this dopamine reward pathway activating all the time. And it is reinforcing by the cognitive fluency and when activated with the mirror engagement. But here's the problem. So, and it was discussed before, and I really love the idea. When you have, for instance, an augmentation on any procedure, you will see maybe 1 week, 2 weeks, and you will see the difference. And so you have the dopamine pathway on. But then it will decrease, as in social media with the likes. So people will look for the next dopamine shot, so next procedure, more validation, etc. And what are the outcomes? This is quite important because our mechanism in the past for survival now are really looking into the self-confidence and the social belonging. Unfortunately, we have a good and a bad thing about psychological burden and the beautiful way to see our lives. So the dopamine reward enhances our self-confidence, so we feel better, we feel belonging, we feel this acceptance, and we generate this pleasure. However, there is a price to pay. Unfortunately, we will compare ourselves with others, and unfortunately our brain is always not accepting us, and we'll see everyone more beautiful than ourselves. And so it will be generating a lot of anxiety, and we will feel that we don't belong, and it's going to create a lot of distress and unreachable. So there is this burden in several diseases, including diseases during childhood and adolescence, and also invisible parts such as face and hands. So people suffering from acne, from melasma, from psoriasis. All of these conditions are not only cosmetic. It's not that they really don't look so good, but the disruption on those things, the sense of belonging, but also the way to try to find a partner, and the signals of symmetry really reflects a problem, and it will drive to a very severe impact on the autoesteem and the self of belonging. But we are our cultural behavior will not only accept the way we are naturally, but we will modify our bodies in order to belong. So we have the biological signal, and we have this cultural amplification. So by pain, by sacrifice, we can alter ourselves in order to have this social belonging, in order to feel that we are part of something. And with suffering, with sometimes it's a diet, sometimes it's exercise, but sometimes it's something really painful for people. They will feel that they belong and they will feel more beautiful. This is nothing only on today's era. You can see different cultures. For instance, in China, the foot binding symbolizes the fragility, but this is so painful, and it's many years trying to alter the anatomy or the neck elongation or the lip plates. So you can see in different cultures, in different times, it's the same idea. So through pain, through something really difficult, and through discipline, people are trying to feel more beautiful and try to belong. Hopefully, and lucky us in the modern era, we don't have to suffer a lot. We can do the same body shifts doing by modern procedures, and here's some examples like breast augmentation, liposuction, etc. And the cultural outcomes, for instance, breast augmentation, it's going to have this ideal of femininity, or the liposuction to have the ideal silhouette, and it's going to be something driven by the culture. In some places, in some countries, maybe you have to be ultra thin. In some others, you have to have a more maybe a body weight better, bigger, etc. And we have to be aware of the cost of this psychological beauty, and BDD is one of the main examples of that, the unrealistic ideals, and also the social media distress. So just a couple of things to finalize. The motivation of beauty involves the evolution, but also the culture and the psychological acceptance. So it's weird to think, and that's why I entitled this lecture as Why We Are Suffering and Why We Are So Obsessed with Beauty, because we suffer to feel beautiful. And we don't suffer for being for have wisdom, or we're not suffering that much to have the knowledge. It's to be beautiful, and this is because all of the rewards, and not only psychologically, the psychological point of view, but also anthropologically, and the social construction is very different. So we try to belong. We try to expand our value, and we try to change the way we look. So the most beautiful skin is not the youngest, it's the one that reflects the healthy, the vitality, and the true self. And this is why people feel more comfortable when they don't look very different to the previous to the procedure. They want to feel like the best version of themselves. Thank you so much, and looking forward for discussion.
Thank you very much, Fernando. So now it's for Dr. Anurag Tiwari. His dermatologist based in India, and he will be discussing the cosmetic correctia identification and treatment. Thank you, Anurag.
And don't forget also that it's those driving forces that keeps us all in business every day.
Very good morning to everybody. It's great to be here in MCAS again. Thank you very much for having me here. Well, something very interesting, the changes which are happening. Dr. Fernando talked about the kind of access which is there with mind and looking beautiful and everything. Well, the 12-year-old history has changed. If I were to ask somebody, what are you doing? What is your actives today? Earlier, it could be cycling. Earlier, it could be running. I'm active. I'm running. I'm doing this. I'm doing that. But right now, maybe that 12-year-old would tell you that, doctor, I'm looking at rotating the 0.5% encapsulated retinol along with copper peptides, etc., etc. So this is what the world is going through. So what is this? Actually, this particular thing is something which is known as cosmeticorexia. And this has been recently defined. It was a previously undefined kind of a condition, but now more and more dermatologists, more and more psychologists, etc., are getting onto it, and it has been redefined as a preoccupation, obsession with achieving a flawless skin at a very early age. So this is also sort of analogous to orthorexia, the healthy eating kind of a disorder, but it's not yet official, but it's on the way and it's on the rise. So that's why we need to be aware about it. So I'm going to talk to you about how to identify this condition, cosmetorexia, and what all can we do for this young patients of ours. Well, the patients will tell that they have sudden onset of irritation, redness, burning, breakouts, despite of that expensive routine skincare. Now, routine skincare at an early age is something not done. So not done. But then that's what is going to happen. You have to ask about what kind of 4 to 5 skincare products daily, layering of active ingredients. Now, all these things are told to these young minds by actives, etc., etc. So they'll put on the salicylic acid, they'll put on the retinol, they'll put on the benzoyl peroxide, and that's where it all creates a chaos. You and I know what it happens, but then the young mind is incapable of understanding. The person who's identifying, the person who's advising is incapable of telling them what to do. They also express intense anxiety or fear regarding premature aging, wrinkles. So imagine it's 12-year-old worried about whatever. So they prioritize your skincare regimen over the other things. So there's a lot of escalation of time and money in the routines which are there. Anxiety when they're unable to perform this particular regimen. If they're not able to wash, they're not able to apply actives, so it creates anxiety. And the skincare affects the regulation of these conditions, and it persists despite the skin irritation, strain, etc., etc. So how do you ask? Well, just ask simple. What's your skincare? How much time do you spend? Do you feel that your skin is never good enough? Do you have had any reactions you've used? So also, once you have those warning signs, do not be hesitant in using the validated tools, the BDD questionnaire, the cosmetic procedure screening, etc., etc. And of course, a pediatric consultation for advanced actives, etc., cannot be overemphasized. So look at those particular signs and symptoms. They're very, very, very simple to look at. Active layer, gerontophobia, a counter congestion. What kind of things you're using? Are you afraid of wrinkles? Are you afraid of aging? So 12-year-old telling you about all these things is something very, very dangerous. What causes this? Of course, this is what is happening. The social media, the cosmeceutical market, the influencers, and the term Sephora Kids, which has been coined by everybody here. Well, this is actually real, and I see it in a country like India, where I belong to. It's not like it's something which happens to doesn't happen to our country. Well, no. We are not so much there, but we are slowly catching up with the rest of the world. Just imagine the 64 million skincare posts. 3 hours is the average time which a 6 to 14-year-old spends. 59% increased skin time over the years, and 9% cosmetic-orexic patient rate in the filler patient has been noted. So these are hardcore data which has been published. It's not something which has been postulated. So lots of differential diagnosis. You need to consult, you need to talk, you need to understand. There could be a BDD happening, there could be an OCD, and of course there could be nomophobia about compulsive digital engagement. Your young person, your young patient is not happy when he or she is not on the social media platforms. So all these things have to be kept in mind when you're consulting these young ones, these unfortunate young ones which are there. These are all photographs which are there, and these are all the warning signs which can happen. It's a harsh reality which happens. What you and I see, we see an irritant contact dermatitis, we see a chemical exfoliation, we see acne cosmetica, and we see an accelerated transepidermal water loss. Well, these are all signs which we, as dermatologists, when you see them in the young mind, young skin, you need to think of cosmeticorexia. Well, this is really happening. The young ones want to know what to use, when to use, how to use. Just imagine talking about retinols when you're about to, instead of talking about bicycles, instead of talking about go-karting, football, whatever, and you're talking retinols to a 12-year-old, and that's seriously scary. That's seriously scary. What do they see? They see a triple acid peel. What has been promised? Well, glassy skin, flawless skin, cell turnover. And what do we get? Chemical peeling at school, cafeteria, lunch table. So this is what the patient complains to you about. I have got peeling in my cafeteria. They talk about retinols, etc., etc. What do they feel? Why they're applying it? Well, I don't want to age. I don't want any dynamic wrinkles. What do we get? A very severe barrier damage. Stale mucin, slugging, still in. They're all doing it. Everybody's doing it. The young ones are also onto it. They want that hyper dewy glazed skin. Acne cosmetica is the thing which we get and which we see. Packaging industry has really made a big headway into selling these particular products to the young one. And it's an irritant contact dermatitis, totally funded by their parental allowances. It's an expensive way to get an irritant contact dermatitis. So what do we do? The first and the foremost thing is complete cessation. Once you've achieved that, which is very difficult, I'll tell you how to do that, you talk about simple cleansing, SINDET cleansing. This is the basic of dermatology revisited, because we as dermatologists can do that. We need to explain to them that you've damaged the skin, you've damaged the epidermis, you've damaged everything, you've damaged the water loss, and this is what you need to do. So SINDET cleansing followed by repair. Repair is by ceramides, cholesterol, fatty acids, the traditional 3-1-1 combinations which are available to us. Those are to be done. And of course, mineral protection with sunscreens because the barrier is damaged. I'm very afraid of prescribing sunscreen to the young ones, but then this is the time when I make an exception and I try to put in these young ones on a sunscreen in case they're going out, in case the damage is too extensive. We sometimes need to put in topical steroids. Then after once you've taken care of the irritant dermatitis, remove it, go on to the topical calcineurin inhibitors, and then sort of remove it out. The idea here is that you have to redirect the behavior of application of multiple things to simple physiological, simple skin care. If you take away everything, they're going to revolt and they're going to do doctor shopping. So do not do that. You try to educate them into getting into something else. So we are shifting. We are from treatment, we are going down to education. We need to educate our young ones. We need to tell them that we will help you. You have had a problem. Don't blame them that you have created to yourself. You have wasted money. You have done that. No, that's not the way to do it. You have to counsel them. You have to get them on board. They have to trust you. You have to build them up that I'm qualified than the TikTok person, more qualified than the TikTok person, and then you take them further. So cleanse, moisturize, and protect. That's a simple thing. Once you tell them, they sort of go ahead with you. And of course, in case the red flags are there, talk to the pediatrician and mental health professionals, because that is the important thing to understand, and and that is something which we have to do. So we need to understand, alert them, who recommends the treatment, why they're doing it, what are the adverse effects, what are the hidden commercial interests which are happening. We need to educate them about the social media. We need to talk about everything in all, apart from doing the consultation for the skin thing. So as we counsel, our primary job is to convince them that the only anti-aging active a 11-year-old genuinely needs is stop staying up after 9 o'clock and stop the scroll. That's one of the very, very important thing which you need to do that. Well, future, there's lots of research which is going on, and we need to have certain public health campaigns on safe skincare, inclusion in the psychiatric classifications, and we should not forget that we are the frontline educators and possibly harbingers. We can predict that some kind of a psychological disorder may happen to this particular unfortunate child in the future. What do I do? It's very, very difficult to counsel. Just confiscate the 14 serum active collection which the child has. Prescribe the revolutionary product, moisturizer only. We have forgotten. We sort of, we have moisturizer only. Then refer to psychology before they shop you to a different dermatologist. And of course, keep those ceramides ready, keep those moisturizers ready. Those small little things which come from all the pharmaceutical companies, hand it to them. They'll be very happy instead of the candy. When they get a dermatological moisturizer, they would be trusting you more than anything else. Maybe this is going to happen. We don't know, and I hope not, that this kind of a thing doesn't happen. With these little things, food for thought, I thank you very much for a patient listening, and I do hope that we identify these young ones and we sort of help them as early as possible so that they don't get into a totally a psychological behavior and do doctor shopping. Thank you very much.
Thank you very much. We had amazing talks here. Do you have some questions for the panel? Yeah, please.
I humbly say what I'm going to say right now probably might disturb you a little bit. Children do what parents do. What they see what parents do. They never do what parents say them to do. So the first thing that Dr. showed about the last slide is already the clear indication, is the clear picture. Now, how many of you have heard about thought field therapy? Anybody? Okay. How many of you have heard about Dr. Roger Callahan? Nobody. Okay. Dr. Roger Callahan was a psychologist, American psychologist, very famous, very famous. Okay, before that, how many of you heard about the book called Psychiatry, the Ultimate Betrayal by Bruce Wiseman? Okay, nobody. Dr. Roger Callahan, a very famous psychologist, very rich treating psychological patients. He, after so many years, found that his work is not working. Psychotherapy is not working. So he started traveling all around the world to find an answer. He reached Eastern world because he found that the Western world are all the same thing that he has learned. So in the Eastern world, he found that there are certain, the Chinese traditional medicine, the Indian traditional medicine, they all have a different approach, a different knowledge. And he was more impressed with the meridian knowledge, the meridian information that we have meridian points, meridian lines in the body where energy flows. That was on one side. Now, the other part he explained is that everything is, I think you believe that what comes physically actually starts in the mind, non-physically. Do you believe that? Okay. So idea may be a non-physical thing, but now then you have created it into a physical reality. So it's absolutely true, right? Now, the bridge, that is just, I think, probably half of the picture. The full picture is the mind, the non-physical, comes to physical only through one thing. That's emotion. Every idea, thought, person, things is associated with an emotion. It has to go through that emotion. It's a bridge. The emotion is the bridge to any physical reality. So what Roger Callahan discovered is the emotion is accepted either positively or negatively. So positively, yes, everybody is happy with it. There are a lot of studies done on this matter. If you go through, you will find a lot, which is not in the mainstream. But what he was more concerned was the negative part. He called any emotion that has a negative connotation or negative association, he called them perturbation. So rightly called, because the root word turb means disturbance in the movement. So children, from child to adulthood, all of us go through mind, emotion, physical, but we have a lot of perturbations. Now, these perturbations are related to memory. So anytime somebody says something, that thought will relate to a memory, and then perturbation is activated. A negative association is activated. So what Roger Callahan found out that it is possible to hit that perturbation and remove the negative association associated with an emotion. He called this therapy, he called this the thought field therapy. But he was able to come up with this therapy only after the knowledge of where the meridians, where the energy flows in the body. Emotion is energy in motion. That's the real definition, actually, if you know it or not. But so he devised this technique called thought field therapy, and he found out that if you tap in certain meridian points, the perturbation seems to dissolve. There were many patients. His first patient was a lady who was so afraid of snakes. Even a plastic snake, if you bring near her, she was like hysteric. So he conducted this simple tapping technique, thought field therapy technique, and then the lady, even after they brought a python near her, and she was able to actually touch her, and there was no fear. There are so many such researches already done. I mean, we don't know in the mainstream. Now, why I'm talking about this is, we talk about so many methods of treatment, you are talking about that dermatology is the psychology, what that word? Okay. Yeah, a beautiful word you were saying that dermatological healing is a psychological healing, right? That's what you were saying. But we are forgetting the most important part is the emotional, management of that particular psychological management. Yes, yes. So once you hit those perturbations, there are another process called the mental processes which help also try to get rid of these perturbations. So I suggest if you want really, really to get your patients away from this particular BDD and all these things, please go through the Roger Callahan books. He's got books regarding thought field therapy. It will help you. Actually, it has helped me also. I tried on myself also. And, I'm more a free man now rather than when I was, before I tried it on myself. And it helped me so I can validate it. Yeah.
Thank you and good morning. My name is Dr. Diab. I'm plastic surgeon from Copenhagen and Sweden. Actually, all the plastic surgeon has some kind of patients. We put them to the surgery only just to make them feel good. We know the operation is done. They are good, but after a while, they need little more operation. We put them to sleep, do little things, and they are very, very happy. My question for you, the relationship between the psychology and the skin you mentioned, how you deal with that? What's your plan after this correlation?
After the correlation between dermatology and psychology?
Yes.
As it was discussed since the beginning of the session, our aim is to flag these patients before undergoing any aesthetic procedures. So we will refer them to a psychologist, for example, in order to help them to deal with their psychological disorders, and then we will be able to treat them correctly and properly.
Yeah, it will be. Is that means that you will have some cooperation with the psychologist to do a plan, like as I mentioned before, we put them to surgery and they will be fine. But are you going to do the same? Maybe because the idea, if I take this, if I do this, I will be good.
Yeah, the idea, as I also said, that we can even have like a psychologist session alongside the dermatological consultation. In some practices, they have also a psychologist in the same clinic. Yeah. Yeah, please.
Okay, it was mentioned earlier in the first lecture, psychodermatology, okay? And maybe just to put all of it together, in psychodermatology, there are 3 clinical models. The first model is that I have a dermatologic conditions. When I'm stressed, the dermatologic flares. So that's the first model. The second model is I have a psychiatric condition, I have body dysmorphia, I go to a surgeon, I go to a dermatologist, they do perfect dermatology surgery, but it only addresses the body, it doesn't address the body dysmorphia. And therefore, you need both. You need to address the psychiatric condition. So that's the second model. The third model is I have a skin condition, but because of my skin condition, I develop clinical depression, I develop then anxiety. So for a cosmetic surgeon, you said, okay, perfect surgery, but then the patient is not happy. They want this done, they want this done. The reason for that is they're not just focusing on the body, it's the body dysmorphia that they're trying to address through cosmetic procedures. And therefore, what we had been discussing is that even before you do any intervention, let us see who the high-risk factor, who the high-risk patients are. And we can do that with screening tools, specifically body dysmorphic. So even before you see a patient, you suspect, oh my God, you are elevated in this, and therefore, you know what? I want us to work together. I want you to be happy. There are concerns that I have, but me as a cosmetic surgeon, dermatologist, I cannot completely address it. Would you be okay that we get a team to help you specifically address your psychosocial condition so that if we address both, you will be completely happy? So that is, in a nutshell, what we are proposing, that we indeed are very good at our field, but there are some patients that they have another unseen layer, and we can protect ourselves by doing the screening tools. Did I answer your question? Yeah, okay, thank you.
The problem with psychotherapy is it's just maybe just step one. It's not the final step. Trust me. I have seen patients, psychotherapy. In the end, they end up in psychiatrists. They end up, first they go to psychotherapist. Later on, the psychotherapist is not able to treat the patient. Then they end up then they themselves, they send the patient to the psychotherapist. As I said, psychotherapist, the greatest psychiatry is the greatest ultimate betrayal. Please read that book. You will be surprised. So the main part is there must be some other method of treatment, or the solution must be added to psychotherapy. Psychotherapy is not the final.
Like what you said. Okay. When we talk about psychiatrists, these are people who are trained in psychopharmacology. And in my country, the Philippines, basically, I would agree, and as in the United States, which our education is basically based on, go to psychiatrist, you're given medications, pharmacology. I do agree that this is, in a way, cosmetic because it eases the symptoms. But I think, as you wanted to point out, there are underlying issues there. I actually chat GPT, Roger Callahan, so it's the FBI. I am familiar with that. But as a psychiatrist, I understand that layer, but I was not happy with that layer because I felt it did not address a lot of basic things. But I didn't understand what are the main issues. So I am a psychiatrist, but I'm a trauma-oriented psychotherapist. And by that meaning to say, because I do trauma therapy, I do EMDR. It's a form of trauma therapy. Similar to what you said, if you're able to undergo to the very molecular issues of this patient, there will be a lot of freedom there. Maybe just to demonstrate similar to that, can I demonstrate to you? Do you know, are you game? Just a few minutes. I want you to close your eyes. Close your eyes now. Play the video of you drinking a glass of water this morning. Open your eyes. What did you feel in your body? Can you describe what did you feel in your body playing that video? Refresh, okay. If I'm giving you 3 words to choose from, positive, you feel very happy, negative, very upset, and neutral, what word will describe that video? Positive. Are you always positive when you drink, or are there times, oh, I just drank water, it just went through the body? Neutral. Okay? Okay, so neutral, but more or less you understand neutral. Close your eyes. Think of a painful memory. Open your eyes. What did you feel in your body? Negative. When you say negative, I'll go to you. I hope you don't mind. Can you describe in your body where you felt that negative?
Because it's related to a painful memory.
Yes, but where in the body?
Heart.
Okay. That is very important because that is the gap I feel in psychiatry. We talk about symptoms, we talk about depression. I understand that. But when what we had demonstrated, where is it in your body? The memory that you said was painful, your body felt it.
Yeah.
But let me ask you, is that happening now? it's just a memory, then why are you feeling it? You're feeling it because, as what you had mentioned, it is an unprocessed memory. And that is where you get all of these cognitive distortions, limiting beliefs that prevent you from moving forward. So basically, when patients come to me, I tell them, I can guarantee you, whatever negative memory that you have, that you feel negative body sensations, we learn a new language. I'm not just talking about emotions. What is your body sensation? I can guarantee you, after EMDR, you think of that memory, you will feel neutral.
Yeah.
What is interesting is that I have done psychotherapy before doing trauma therapy, and I agree with you, it's so hard, even in psychotherapy, to deal with this, because every time you think about that memory, you get these negative body sensations. What I had realized is that when I do trauma therapy first, I neutralize it. I identify what the negative cognition is, it's able to move forward. For instance, the memory was a particular memory. I have negative body sensations. My cognition is, I have a bad mother. We do EMDR. You know what? That memory is neutral. What happens there to that cognition is sometimes it just moves automatically without me even talking about it. But only on psychotherapy, it becomes, oh, you know what? My mother was in a bad situation. The shift there is sometimes what I observe in the patients. We don't talk about, in fact, in EMDR, it's only bilateral tapping. We don't talk. But the patient, because we're able to reprocess that neuron, the patient is able to move the cognition from a negative cognition towards a neutral cognition, which is aligned with the neutral memory as well. If that doesn't happen, that is where we do talk therapy. But unlike before, when we talk about talk therapy, it is so much easier because there's no more negative body sensation that hinders it. So that is basically how I'm able to integrate trauma work with psychiatry, because I'm a psychiatrist, and also with dermatology. And I think with that, I hope I was able to, explain how we're able to integrate it. And I also like the other topics discussed. Yes?
What you said is, my opinion, is just part of the mind's part. Because mind, and then you got emotion, and then you got thought. Why does surgery work? Your question was why surgery is working is because the physical part, surgery is taken care of. If we work only on mental aspect and we don't work on physical aspect, it does not work. That's why I think Roger Callahan's tapping technique works, because he is doing something physical in association, in addition to the mental part.
Amazing, guys. Thank you very much. We need to close the session. Thank you all.